Okay, so thank you for the introduction, Dr. Moldina. So I was asked to give a talk on the use of vasopressors and inotropes in the intensive care unit. This is going to be a case-based presentation. So we're going to walk through a case that I saw in one of our community sites a couple of years ago that I think was just kind of a nice illustration of how to kind of conceptualize the use of vasopressors. I'm sorry, just give me 2 seconds. Okay, so I admitted a patient to the intensive care unit. So he was a 58-year-old male, had a history of alcohol use disorder, hypertension, and hyperlipidemia. And he ended up presenting to the emergency department with chief complaints of shortness of breath, fever, and lethargy. So on presentation in the ED, his vital signs demonstrated a temperature of 39.2 degrees Celsius. He had a heart rate of 112 beats per minute, respiratory rate of 24 breaths per minute, and his blood pressure at that time was 90/46 with a MAP of 61 millimeters of mercury. And so these were the initial labs that were taken when he was in the emergency department. So I think the main things that jumped out was he didn't have any history of chronic kidney disease. So the creatinine of 1.85 was definitely above what we'd suspect to be his baseline. He had a white blood cell count of 22 with a left shift and a percent bands of 8. His lactate was also 6, giving concerns for hyperperfusion, which we'll get into in a little bit. Otherwise, LFTs were unremarkable, lipase was normal, troponins were negative, EKG didn't show any ischemic changes at that time. And so this was some of the imaging that was done with him. So as you can see on the chest radiograph on the left of the screen, so this is showing a right-sided pleural effusion. And then this is a picture of what the ultrasound or bedside thoracic POCUS showed that was concerning for loculated pleural effusion. So at that time, we placed a chest tube. So the right picture, or the picture on the left side here this is one of our typical chest tube kits. It's a pigtailed catheter that was placed. And on the right side, this is a actual photo of some of the fluid that was taken. So you can probably ascertain that there was some concern that this was going to be purulent and related to either a pneumonic effusion or a parapneumonia or a empyema. So the pleural fluid ended up being consistent with empyema. So the patient was started on piperacillin, tazobactam, and vancomycin. We sent blood cultures, pleural fluid cultures, MRSA nasal swab, and then urine, Legionella, and pneumococcal antigens. He ended up receiving 30 cc's per kg of IV crystalloid. So this is per the surviving sepsis guidelines. He didn't have any absolute contraindications to giving the full dose, so no history of end-stage renal disease or heart failure at that time. But unfortunately, despite the resuscitation, he remained hypotensive, with the most recent blood pressure being 85/50 with a MAP of 55. A bedside ultrasound exam was done, which showed the IVC was distended and it was non-collapsible. A central line was placed into the right internal jugular vein, which demonstrated a CVP of about 14. And then an A line was also placed, which showed no pulse pressure variability. If anybody doesn't mind chiming in, what do you guys want to do next? So given that the patient had received the appropriate amount of crystalloid at that time, the decision was made to start the patient on vasopressor support. So this is kind of some historical data that, or historical study that we looked at initially, especially when I was doing my training about resuscitation in sepsis and septic shock. This is a paper by Emmanuel Rivers out of Detroit that was looking at kind of a different approach at the time in 2001 of looking at very specific hemodynamic parameters to try to optimize in a very algorithmic way to try to improve outcomes. So one of the first things that Dr. Rivers and his group looked at was trying to optimize the patient's fluid resuscitation. So as you can see, after applying supplemental oxygen, intubating the patient if they needed to be, and then placing appropriate IV access with a central line and then an A line, one of the first parameters they looked at was central venous pressure, which, in this case is going to be a measure of right arterial pressure or end diastolic RV pressure. So if the CVP was less than 8, they administered either crystalloid, so lactated ringers or normal saline, and then colloid to try to get the CVP between what they optimize as being 8 to 12 millimeters of mercury. And so this is some of the results from that study. It was pretty profound looking at in-hospital mortality, where looking at all patients, so ones with severe sepsis, septic shock, or sepsis syndrome, there was a significant improvement in mortality with a p-value of 0.009. This ended up translating to a number needed to treat of 6 and a relative risk reduction of 32.2. So at the time, it was a pretty groundbreaking study. CVP is definitely something that we had leaned on, especially after that paper was used, but that's a very static look at hemodynamics and fluid resuscitation. And we use more dynamic assessment today to try to get a good estimation of how the patient's doing from volume status. So on the left side, this is looking at pulse pressure variation on an arterial catheter. So your pulse pressure is going to be a P max, as you can see, which is going to be the largest on the arterial waveform on the graph at the bottom, minus the minimum. And that's going to be over the max plus the minimum divided by 2. Now, pulse pressure can have some false positives and false negatives. So some of the false positives you can get with determining if a patient is volume up or volume down is going to be if the patient is spontaneously breathing, if the patient has any cardiac arrhythmias, which we'll get to in a little while, and then if they have increased intra-abdominal pressure. And then some false negatives are going to be if the patient has a low tidal volume, low lung compliance, or has a very high respiratory rate. And so just from an algorithmic standpoint, this is one of the ways that you can kind of conceptualize the use of pulse pressure variation when trying to optimize fluid resuscitation in your patients. So looking at the graph primarily in the middle, again, we're kind of, this is most effective in patients that are under mechanical ventilation with no spontaneous breathing and, again, having no cardiac arrhythmias. We're going to look at that equation. If the pulse pressure variation is greater than 13%, fluid responsiveness is likely, again, with the caveat if there's no RV failure or intra-abdominal hypertension. If you're not sure, you can always perform a passive leg raise, which is still the gold standard in determining if any further volume resuscitation is going to be advantageous for the patient. If the pulse pressure variation is greater than 9%, but then less than 13%, you can consider doing a tidal volume challenge. So this would be moving the patient's tidal volume. If they had ARDS, for example, and their tidal volume is 6 cc's per kg, moving it up to 8 cc's per kg to see if that changes anything. And then if the pulse pressure variation is less than 9%, and if they have a tidal volume of greater than 8 with a compliance of greater than 30, fluid responsiveness is unlikely. And then if the tidal volume is less than 8 cc's per kg or the compliance is less than 30, then we can also consider a tidal volume challenge at that time. One thing we also look at is looking at VTI, which is an assessment of the left ventricular outflow tract and trying to assess whether the patient would respond to volume resuscitation. So this is a little bit outside the talk, but it's definitely something that we've been pulling more into our practice, is the use of bedside ultrasound to help guide us with not only vasopressor support, but also volume resuscitation. This is the Andromeda study. So this looked at another assessment of how we're doing from volume resuscitation. So with cumulative mortality on the vertical axis and then time on the horizontal axis, you can see that the use of lactate versus peripheral perfusion, there was no significant difference between the two at 28 days out. So you can use either. And then this is just an assessment of all of the different subgroup analysis that they had determined ahead of time. It definitely looks like peripheral perfusion is more advantageous in looking at a SOFA score of less than 10, which you can see down here, with the hazard ratio being to the left, favoring peripheral perfusion. And then just considering volume resuscitation just generally, the two graphs at the top here are taken from a large database out of the state of New York, looking at how the time of completion of a IV crystalloid bolus changes outcomes. So the in-hospital mortality on the left, so the one on the left is in an adult population. You can see that there was no significant difference when the fluid was completed. But if you look at the right, you can see that the difference in mortality, the longer that it took for the completion of the IV fluid bolus and the longer it took to actually administer that IV fluid bolus in a pediatric population definitely affected inpatient mortality. On the flip side, if you look at the administration of antibiotics for these patient populations, in-hospital mortality in the adult population was very much tied to how quickly antibiotics were administered, where in the pediatric population, it was more tied to when the time to completion of the IV fluid bolus was. And the part on the bottom is from another study out of 2005 from Schock that was looking at fluid resuscitation using a liberal fluid resuscitation or restrictive fluid administration. And they found that fluid overload is common after treatment with early goal-directed therapy, which was that paper that we initially looked at from Emmanuel Rivers. And they found that giving too much fluid can actually worsen some clinical outcomes. So just one thing to keep in mind that we want to consider fluid, whether that's going to be crystalloid or colloid, definitely a medication when we're administering. That can have both positive and negative effects. And so, we've already given the 30 cc's per kg to this patient, and we saw that the CVP is going to be within our goal. And so the next thing is, if we still haven't kind of developed the stability that we're looking for, now we're going to assess the MAP, which we saw in the patient was low. So from the Emmanuel Rivers paper, they were looking for a mean arterial pressure of at least 65. And if they weren't able to reach that, then they were going to administer vasoactive agents. So I guess the next question is going to be, we're going to start a vasopressor, but what's going to be our target mean arterial pressure? So this was one from the New England Journal of Medicine in 2014. And what they were looking at was, is there going to be any difference in clinical outcomes if we target a high MAP, so that's going to be 80 to 85 millimeters of mercury, versus a lower MAP, which is going to be 60 to 65. The graph on the left is showing the variability in each patient group with those different targets. And on the right, as you can see, looking at cumulative survival, there was no difference between the two. They found that that serious adverse events weren't different between the two groups. They did notice a higher incidence of newly diagnosed AFib in the higher target group, but they also found that in the lower group, there was a higher need for renal replacement therapy if they already had chronic hypertension. So generally, our target is going to be a MAP of 65 to make sure that we have adequate perfusion and to try to reduce tachyarrhythmias. Okay, so we decided we're going to start vasopressor support. We're going to target a MAP of greater than 65. So which vasopressor are we going to lean on? Yep, exactly. So for our septic shock patient population, generally norepinephrine is our first go-to for vasopressor support. You can see it on the graph here. Norepinephrine has a lot of advantages. So it has both alpha-1 and alpha-2 activity. So that's going to be your peripheral vasoconstriction, but it also provides beta activity. So this is going to help with chronotropy and inotropy as well. And so just kind of thinking about the ways that the use of norepinephrine is going to be advantageous. So it's going to, as I just previously mentioned, it's an agonist for our alpha receptors. This is going to increase the intracellular calcium, causing vasoconstriction, but also has that beta agonist activity. So also increasing intracellular calcium and then providing chronotropy and then inotropy as well. So this is from the SOAP2 trial from 2010. They looked at the use of norepinephrine versus dopamine in various shock states. So the graph on the left shows probability of survival on the vertical axis, and then days since randomization on the horizontal axis. And as you can see, with a p-value of 0.07, there was no difference between the two. But if you look at the breakdown of the a priori identified subgroups on the left, you can see there's a difference in the hazard ratio between norepinephrine and dopamine. I think this is all very much tied to the amount of arrhythmias that they saw. So with the numbers on the left-hand side here being the dopamine group and the ones on the right being the norepinephrine group, you can definitely see that there's a higher percentage of arrhythmias in the patients that were receiving dopamine. And this is very likely due to the fact, or this likely contributed to the fact that cardiogenic shock patients had a lower mortality in the norepinephrine group as opposed to the dopamine group. So generally, dopamine has come out of our clinical practice. We're going to talk about the use of dopamine a little bit later on when we're talking about chronotropy, but generally for that kind of first line vasopressor and septic shock, or even second or third line, we definitely stay away from dopamine. Or at least, I'm sorry, at least I generally stay away from dopamine. So going back to our case, so despite broad spectrum antibiotics and IV crystalloid resuscitation, the patient's norepi requirements continue to increase. And so currently he's receiving 8 micrograms per minute of norepi, and this is to maintain a MAP of 65. So what do you guys want to do next? So generally, as part of my clinical practice and a lot of my partners, this is usually the time when we're going to consider starting vasopressin. So vasopressin has multiple areas or multiple receptors that it affects in the body. The first one is going to be the V1 receptor. So that's at the bottom there, circled with a red square. So this is going to cause vascular smooth muscle contraction, and this is going to be primarily what's driving the increase in blood pressure. It's also going to cause water reabsorption in the kidneys, and it's also going to produce an increase in the production of ACTH from the pituitary, and this is going to increase cortisol production. So there were a lot of studies in the late 1990s and early 2000s that showed that in patients that have sepsis and septic shock, this causes an endogenous ADH depletion. So even though we think of vasopressin as a vasopressor, I think from a physiologic standpoint, what we're actually doing when we administer it is trying to increase the natural depletion of endogenous ADH that we see by administering it at that time. And then there's some other advantages with the V1 receptor, although it works very similarly to the alpha and beta receptors that we talked about. It's a G protein coupled receptor. It's going to increase cellular calcium. But the nice thing about vasopressin is it's not present in the pulmonary arteries. So if you have a patient that has pulmonary hypertension, vasopressin is not going to cause any worsening RV dysfunction. And then if it also is not present on renal afferent arterioles. So this is not going to affect renal perfusion. So two nice advantages to the addition of vasopressin in this patient. And so this comes from the VAST study. So what they looked at was the initiation of vasopressin in addition to norepinephrine. So if you looked at probability of survival in these patients, and then days since the initiation of the study drug, there was no difference. But if you looked at, again, that a priori subgroup analysis, they looked at more severe septic shock. So these are patients with a norepinephrine group of greater than 15 micrograms per minute. And their hypothesis was that these patients with a more severe septic shock state was actually going to show mortality benefit with the addition of vasopressin. And they compare that then to the less severe septic shock population. So this is going to be norepinephrine of 5 to 14. And actually what they found was different than what they were expecting. So it was actually in that less severe septic shock population, that addition of vasopressin actually portended a mortality benefit looking at 90-day mortality, and then was very close to being significant for that 28-day mortality as well. So this is a retrospective study from Critical Care Medicine in 2022. And say what they looked at was the effects of when vasopressin is initiated for patients that are in septic shock. So looking at the graph here on the left, with the probability of in-hospital mortality on the vertical axis, and then the norepinephrine dose on the horizontal axis, you can see that the early initiation of vasopressin in this observational trial portended better outcomes. The graph in the middle is looking at initiation of vasopressin in relation to the patient's lactate. So if vasopressin was started earlier or started at a lower lactate level, that this portended a better in-hospital mortality. And then if you looked at the initiation of it with an onset of septic shock, it also had a better mortality effect. So kind of long story short, early initiation of vasopressin in these patients was advantageous before signs of systemic hyperperfusion. And then usually at this time, again, this is kind of outside of this talk, but this is also at the time that I usually add hydrocortisone. Also, depending on your own practice, whether to add fludrocortisone as well. These two graphs are from the adrenal study, which was one of the more recent studies looking at hydrocortisone in patients with septic shock. Although in that particular study, it didn't show a survival benefit, it definitely showed a faster time to resolution of shock. And this is also taken with the caveat that there are other studies. So Dr. Anand's study and then the Approaches study that did show mortality benefit. Well, so I don't know whether necessarily steroids have a mortality benefit, but I know it's going to cause resolution of shock quicker. So I'm adding it at this time with the idea that this is a point where we're considering refractory shock because we're adding a second vasopressor with the addition of vasopressin. So going back to our case, so you're called emergently to the patient's bedside. And so on your exam, the patient is found to be in AFib with rapid ventricular response. So currently, the patient's vasopressor requirements are norepinephrine at 15 micrograms per minute, and then vasopressin at a fixed dose of 0.03. That's also something I should have mentioned before, but generally, this is very different than what we were doing decades ago, but we don't titrate vasopressin. When we add it, we're adding it at a fixed dose, usually at 0.03 or 0.04 units per minute. But going back to the case, so we attempt cardioversion. Unfortunately, that is unsuccessful. And so then the patient is bolused with amiodarone. So what do you guys want to do next? So this is generally a case where I'm giving some consideration to stopping the norepinephrine and then starting phenylephrine. So kind of going back to that graph of our catecholamines. So phenylephrine at the bottom here, this is a purely alpha agonist, so it's not going to have any of that beta activity that we were talking about. So you're getting that vasoconstriction, but you're not having any of that positive chronotropy or positive inotropy from it. Kind of generally, I consider phenylephrine to be an inferior vasopressor compared to norepinephrine and epinephrine. It doesn't have any inotropic effects. And then that kind of pure afterload is going to be detrimental in patients with cardiogenic or mixed shock. However, taking that into consideration, phenylephrine is less likely to cause tachyarrhythmias. This is because it doesn't have any of that beta receptor activity that we were discussing. However, this total effect might be a little exaggerated looking at more recent studies. So this is from CHEST in 2022. So it was looking at patients with atrial fibrillation that were started on phenylephrine versus norepinephrine. So with the full cohort of patients being on the far left, the patients that were in rapid ventricular response in the middle, and then the patients that were in AFib without rapid ventricular response on the right, you can see that the differences in the heart rate compared from phenylephrine compared to norepinephrine at its most robust showed a difference of 6 beats per minute in any of the groups. So the patient is eventually weaned off of vasopressor support, and he's returned to normal sinus rhythm at this time. 1 day later, when assessing the patient in the morning, the labs are significant for a high anti-GAP metabolic acidosis, transaminitis, acute kidney injury, and lactic acidosis. Vital signs at that time demonstrated a blood pressure of 85/60 with a MAP of 68, and the heart rate at this time is 90 beats per minute. A formal echo that was done when the patient was admitted was relatively unremarkable, showing an LVEF of 60 to 65%. At this time, you order a repeat echo that demonstrates a LVEF of 15%. So at this point, we're starting to suspect that the patient may have developed a sepsis-induced cardiomyopathy. What do you guys want to do next? So at this time, I'm giving a lot of consideration to placing a pulmonary arterial catheter and then starting milrinone. So this is a graph looking at our patient or medications that we're considering for inotropy and chronotropy. So looking at the activity of the receptors that we were discussing before, we're not getting basically any alpha agonism from these medications, and we're more focusing on the beta agonism, given that chronotropy and inotropy. So this is probably the only point that I would give any consideration to starting dopamine. It's going to be, again, to try to increase a patient's heart rate, not for this particular patient, but if a patient is developing symptomatic bradycardia. And then there's also isoproterenol, which again is going to be primarily for bradyarrhythmias, with it only having beta activity. So then thinking about what medications we're using for inotropic support. So these are going to be primarily dobutamine and milrinone. And this is also kind of going back to that stepwise assessment to resuscitation in these patients. So, if a patient isn't having the correct cardiac output that we're looking for, and this can be assessed looking at central venous oxygen saturation. So whether you have a central line, or if you have a patient that has a pulmonary arterial catheter, looking for a goal, at least according to Dr. Rivers' paper, of a 70%. And if you can't reach that, then adding an inotrope to get to that. We definitely don't use the transfusion of red cells as our guideline here anymore. We primarily target a hemoglobin of 7 for these patients. One caveat to pulmonary arterial catheters: they have not been shown to improve mortality, ICU length of stay, or hospital length of stay. But they do allow for accurate titration of inotropes, and especially for patients that are on mechanical circulatory support. So this is going to allow us to assess the patient's central venous oxygen saturation, their cardiac index, and their cardiac output. I think for patients, particularly if they have a, they're on mechanical circulatory support, or for patients that are in overt congestive, in cardiogenic shock, the Swan-Ganz catheter can be very helpful. But we have also been using bedside ultrasound more and more in our clinical practice. And so this was a study from the New England Journal of Medicine looking at patients that were, again, this is retrospective, but they were looking at patients with milrinone versus dobutamine in cardiogenic shock. And as you can see, in the primarily composite outcome on the left, and then in hospital death from any cause on the right, there was no significant difference between the two. So either one would be appropriate. Just some things to consider when you're choosing between the two. So milrinone can cause a drop in systemic vascular resistance. So dobutamine may be preferred in patients that are already hypotensive, so a patient that's already in a shock state. And then for patients that have any renal failure, or chronic or AKI, milrinone is predominantly renal metabolized, so dobutamine may be preferred in these patients. So just some conclusions. Dynamic measures of fluid responsiveness, such as pulse pressure variation and VTI, are becoming more preferred over static measures, such as CVP. In septic shock, a mean arterial blood pressure of 65 should be targeted in most clinical scenarios. Norepinephrine is the vasopressor of choice in most shock states. The early addition of vasopressin and glucocorticoids in septic shock can improve outcomes. Phenylephrine is less likely to produce tachyarrhythmias. However, it is an inferior pressor compared to our other catecholamines. And then milrinone or dobutamine should be considered for inotropic support in patients in cardiogenic or mixed shock. These are my references. And I'm more than happy to answer any questions that you guys have. Also, that's my email address at the bottom. I'm more than happy to respond later on if you guys have any questions going forward.
Thank you, Dr. Bonk. Thank you very much for that great summary on vasopressors and inotropes. If anyone has any questions, please, you're very welcome. You can unmute yourself and ask if there's anyone who has any question for Dr. Bonk. If I may start, what criteria? Let's say if you have a patient, so we discussed patients who do not have any underlying kidney disease or liver failure. What if you face a patient who has an underlying renal failure, liver failure? How would your approach for vasopressors and inotropes be in that patient?
Yeah, no, that's a really good question. And that was kind of one of the things I was thinking about with the caveats when we're shooting for a mean arterial pressure of 65. The main thing you worry about, especially with patients that have underlying cirrhosis that come in with any acute kidney injury, the thing that we really fear in these patients is that they're developing hepatorenal syndrome, which portends a very high mortality. So, for those patients, targeting a higher blood pressure of 80 millimeters of mercury can be helpful if you're using norepinephrine as opposed to using octreotide and midodrine for those patients. So definitely for those, I'm targeting a higher pressure. As far as acute kidney injury, that generally doesn't change my practice, but it's definitely more those patients with underlying cirrhosis, and in particular, if they with cirrhosis as a disease state, really being an alteration in the metabolism of nitric oxide. Those patients that are coming in with a baseline, they're baseline hypotensive or hyponatremic. Those are definitely ones I'm much more concerned of that are developing hepatorenal syndrome.
Thank you. Anyone else with any question?
Dr. Bonk, this is Dr. Perryman. I have a question. So when you do, I find doing capillary refill at the bedside, I like doing it. I find that I get good responses, but somehow I don't. It's not necessarily standardized. I think the Andromera study, they talked about putting a slide on the ventral surface of the digits. What do you do, and how do you use it at the bedside?
No, I think that's a really good point. I think generally with capillary refill or any of these approaches that we're doing, looking at fluid responsiveness and resuscitation, I'm not using one particular parameter. Using the capillary refill, kind of as you were describing that they used in the particular study design, taking that into consideration with lactate, with a CVP, with our bedside ultrasound, and kind of putting that all together to get a good assessment. I think I generally don't rely on just one parameter for my guidance of fluid resuscitation, if that makes sense.
No, it does. And can I ask you one more question? If your mixed venous is in the 50s, and you have a way to assess cardiac function, you think the cardiac output is down or the EF is down, and somebody who doesn't necessarily have chronic heart failure, will you and you use milrinone or whatever to bring up the cardiac output, but your mixed venous remains down, and your hemoglobin is like, let's say 8, 9. Will you transfuse a unit of blood, or do you not transfuse blood to bring up your mixed venous?
I generally, if the hemoglobin is that high, like around 8, I generally don't. But I think it also depends on what your patient population is. So, I think Dr. Puri, as you were alluding to, patients that are, a post-cardiac surgery patient, you may be more aggressive in trying to bring up their hemoglobin to reach those goals. But in a purely septic shock population, I don't.
Thank you.
Thank you. I see Dr. Saif is here. Dr. Saif, would you like to say something? Dr. Saif is a critical care physician in Washington. So maybe if you would like to share your experience with.
Yeah, no, thank you for inviting me. Great presentation. It's always great to review the data that our practice is based on. So a great presentation of the data. If I force myself to make one comment is, I think we're seeing a change in practice in the volume resuscitation. We just published a paper looking at patients who received more than 30 cc's per kilogram of fluid in septic shock, and found there was actually an increased mortality once you get to over 50 cc's per kilogram. And so it's as stated clearly, early vasopressors and then judicious use of fluids. I liked the term on the slide that said fluid is a medicine, and the hyperchloremia related to it. I'm sure it's a separate topic and a separate talk, and using pH buffer neutral solutions. But I think that's among the many changes in practice, that earlier vasopressors and not overloading with fluids is a trend that we're seeing in our practice.
Yeah, no, I completely agree. And actually, Dr. Saif, if you wouldn't mind sending me the reference to that paper, I'd love to read it. So, when you look at, before the Rivers paper, we were, really under resuscitating patients. At least that, that was the theory. And that's why the outcomes in septic shock were so much worse than we saw after Rivers. But I totally agree that, the consideration of using, either IV crystalloid or IV colloid is definitely the administration of a medication. If we don't kind of address once we get out of the resuscitative phase and then we get into deresuscitation to try to get them back to euvolemia, it's definitely going to be associated with, and it has been shown to be associated with worsening outcomes in some trials.
Yeah, and so hence the points Dr. Pierman made about fluid response assessment of serial fluid responsiveness is the optimal way to give fluids. I agree.
Can I ask the two of you guys, and then anyone on the call, do you how do you use vasopressin? You use it like the VAS trial, or like how early? I mean, if Levoped's the first choice, how early are you guys going to vasopressin based off the data you showed, Dr. Bonk?
I was actually going to first title this presentation "A Love Letter to Vasopressin," because I had to take a bunch of slides out about vasopressin. I generally, based on the VAS trial, was pulling the trigger for it at about 10 micrograms per minute. Again, at the same time when I'm adding hydrocortisone, but looking at that observational trial showing better outcomes, I may start changing my clinical practice to actually starting it earlier. But Dr. Saif, what are your thoughts?
Yeah, I'm purely a vast person using vasopressin. So when it's over 15 and it's refractory, I use it knowing that it's gonna maybe shorten my length of stay. It's not a mortality outcome. A few years ago, there was a shortage of vasopressin, and hospitals were actually discouraging using vasopressin unless it was really high doses. But that has changed some practice as well. That has remained even though that shortage has gone away. But I'm purely a VAST trial user, and I don't find mortality or outcomes that I think are reliably defensible at this point. But more data needed, of course.
I guess one thing too, just in consideration of the use of vasopressin, I didn't include this, but when you're thinking about your weaning of vasopressors, again, these are observational trials, so hypothesis generating but not conclusive is that you see less refractory hypotension or recurrent hypotension rather if you wean off the norepinephrine first and then leaving the vasopressin on to be your last vasopressor off, as opposed to the opposite. So again, these are just some smaller observational trials, but something to consider.
Okay, thank you all for that discussion. So I think maybe if there's no further comments from anyone, maybe I'll wait a few seconds if there's anyone who wants to say anything. Yeah.
So I got one comment, and actually it is a question. I think that there is a situation that you get the patient, you have given the fluid according to the 30 cc per kilogram, then you have assessed the inferior vena cava, you have seen that is full dilated, you have initiated the vasopressors, and some articles says that we need a maximum dose of 2 vasopressors to say this is a vasopressor resistant shock, then you initiate hydrocortisone. So my question or my argument is to know if there is anything bad can happen to the patient if you initiate early as possible that vasopressors, hydrocortisone, instead of waiting maximum doses of vasopressors and then initiating those hydrocortisone. So is it advised to start hydrocortisone as early as possible? Thank you.
No, that's a great question. So there was a trial that in the 2010s, I believe, that looked at the addition of corticosteroids in patients that had sepsis and severe sepsis without septic shock, and they showed no difference in then the development of septic shock. So I think in patients that aren't showing signs of shock or systemic hypoperfusion, the addition of early hydrocortisone is not necessarily going to change outcomes.
Thank you, Dr. Joffre, for that.
Can I add one point to that?
Yeah, sure.
Yeah. I mean, I completely agree with that. But one more thing that I also do is like once we start vasopressors, and after the first, how soon we win it off also depends on whether the person is a responder or not. So obviously, when you start it, you don't know if that person is going to be a responder or not. But if they weren't a responder, and you're still using the same vasopressors, I tend to wean it sooner. By 2 or 3 days, I tend to wean it off as opposed to continue a full course.
No, that makes a lot of sense. And actually, one caveat I should give is, especially looking at pneumonia and severe pneumonia in hospitalized patients, there's been a lot of data kind of back and forth using the addition of corticosteroids to improve outcomes. The Cape Cod trial came out not too long ago that showed improvement with the addition of hydrocortisone with a taper for those patients. So I guess one thing to give some consideration is what the source of the infection is. If the patient does have a pneumonia, I agree with you about what was being said, that you may want to give some consideration to the addition of hydrocortisone early based on that trial. Or if the patient has ARDS also.
Yeah, my practice is to, by the time I'm on the second vasopressor, I will add steroids. Because, there's occasionally a patient who's steroid responsive and that you're not able to pick out. That seems to improve. I haven't found a lot of mild or defective steroids, but that being said, it's not that I'm evaluating each patient for getting new infections, but that's just my practice. And I use both hydrocortisone and fluticasone.
When I was a resident, we were doing cord stim testing on all patients with sepsis or septic shock in the ICU, and we had to do our own blood draw. So I'm definitely very glad that we've gotten away from that particular practice, just from a time management standpoint.
You're aging yourself, Dr. Bonk.
Okay, thank you everyone for those comments and for the participation. I put a link in the chat box for feedback. So please do let us know what you thought of this session and of the monthly webinars in general. And if you have any ideas or any suggestions for future topics, please do write that in the forum as well, so we can try and include them in the future webinars. So once again, thank you, Dr. Bonk, for coming, for also waking up so early just to teach us, and at 7 a.m. your time. Dr. Nitin, Dr. Saif, thank you also for joining, and everyone else on the call. Thank you all for coming, and I hope we'll see you again in the next webinar.
Yeah, and thank you guys so much again for the invitation. This was a lot of fun. I'm more than happy to come back if you'd like.
Thank you. Thank you very much.
Thank you. Take care.